Siyasanga, Yekani, who's a registrar here at Holistic Investor Cape Town, who's been presenting to us the approach to a patient with recurrent UTIs. So if you can start sharing your slide, please.
Okay. Sorry, Sam, I'm just trying to. Can you see my screen now?
Yes, we can.
Okay. Thank you. Okay, so my name is Sia, and today I will be speaking on approach to recurrent UTIs. So as part of my presentation, I'll start with an introduction and I'll go into epidemiology, risk factors, pathogenesis of recurrent UTIs, the diagnosis, management, and lastly, conclusion. So as an introduction, UTI is basically defined as colonization of the urine with bacteria plus inflammation and invasion of the urinary structures. Because of the contiguity of epithelial surfaces of the urinary tract, it places the entire system at risk of infection. So essentially, adequate management begins with accurate classification as an initial step. And you can basically classify urinary tract infections as complicated, uncomplicated, and recurrent. So complicated UTIs will basically occur in patients with structural and functional voiding abnormalities, obstruction, neurological disease, stones, conditions predisposing to infection, and in the elderly. Uncomplicated UTIs basically occur in otherwise healthy patients, which will have structurally and functionally normal urinary tracts, where there's absence of obstruction at any part of the urinary tract. With recurrent UTIs, we define them as more than 2 infections in 6 months or more than 3 in 1 year. It's typically an acute simple cystitis rather than a complicated UTI. And they basically occur after documented successful resolution of the antecedent infection. And it can be divided into 2: reinfection, where there's a new event associated with reintroduction of bacteria into the urinary tract, or bacterial persistence or relapse, where there's multiple infections with same bacterial type, and it originates from a focus within the urinary tract. Most of these recurrent UTIs represent reinfection rather than relapse. In terms of its epidemiology, it's common among women, even with anatomically and physiologically normal urinary tracts. In women with first episode cystitis, 27% had at least 1 culture-confirmed recurrence within 6 months, and 2.7 had a second recurrence during the same time period. It's usually not a life-threatening infection, but the high incidence increases healthcare costs and has negative impact on patients' quality of life. E. coli is the most common organism causing UTI recurrence, and other organisms include coagulase negative staph, Klebsiella pneumonia, Staph aureus, Group B streptococci, Pseudomonas, and Proteus mirabilis. And then in terms of risk factors for recurrent UTI, they can be divided into behavioral factors. So sexual intercourse, basically how much you have of that. Diaphragm spermicide and spermicide-coated condoms. And then a case control study of women with or without recurrent cystitis showed that frequency of sexual intercourse is actually the strongest risk factor. Spermicide used during the past year, new sex partner during the past year, first UTI at or before 15 years of age, a positive history of a mother with UTIs. There was, however, no association, as previously thought, with the pre and post coital voiding, frequency of urination, delayed voiding habits, wiping patterns, douching, using of hot tubs, use of tights or pantyhose, and BMI. And then in terms of host factors, they can be divided into mechanical or physiological factors. Mechanical factors include physiological factors include urinary incontinence, presence of a cystocele, and increased poised void residual urine. And then in terms of genetics, as I said before, if you have a history of a positive mother, a mother who's had UTIs or has a history of UTIs in childhood, the lowest blood group non-secretor phenotype, which tends to be overrepresented amongst females with recurrent UTIs, and increased, which then causes increased adherence of uropathogenic E. coli. And then hormonal status, which is important in postmenopausal women, where there's lack of estrogen leading to decreased glycogen and thinning of the epithelium. And subsequent alkalization of the vagina, which decreases the lactobacillus, and then basically leads to GNB uropathogen invasion. Other factors, basically predisposing illnesses such as diabetes, CKD, renal transplant, polycystic kidney disease, HIV and AIDS, and immunosuppressant medication. There's also nosocomial factors or instrumentation, which includes indwelling catheters, exposure to multi-drug resistant bacteria, the presence of a nephrostomy or ureteral stents. And then in terms of pathogenesis, as I said, E. coli is the most common cause of UTI. The isolates that cause UTI are termed basically uropathogenic E. coli or UPEC. And these achieve infection from two possible pathways, So firstly, from frequent repeat ascending infections or chronic persistent infections in the bladder, which can be secondary to or from bacterial factors or deficiency in host defenses. So in terms of bacterial factors, the cause may be from gram-negative or gram-positive bacteria, most commonly E. coli. There's several specific strains of E. coli that have been found to be increased in recurrent UTIs. Virulence factor genes and adherence factors from these E. coli strains are associated with persistence and relapses. There's also intracellular bacteria communities or IBCs, which facilitate survival of bacteria on the bladder. Basically, E. coli tends to attach to the bladder epithelium. There's internalization of this bacteria into umbrella cells, leading to rapid growth and division. And then there's a phase where the bacteria is basically quiescent as an intracellular reservoir, which is basically biofilm-like. This shields pathogens from antimicrobials and also from the host immune response. And then with regards to deficiencies in host defense, it can basically occur in immunocompromised and immunocompetent patients. They're both at risk. So there's basically two main mechanisms. And first one is the innate immune response, and the second one is related to the urothelium barrier function. So the innate immune response basically includes all the inflammatory cells and recognition cells, such as toll-like receptors. And then with regards to the urothelium barrier function, we know that the urothelium is the first-line barrier against pathogens. It secretes pro-inflammatory cytokines and protective glycoprotein plaques, such as uroplakin or termhosphold protein. Basically, with patients with recurrent UTIs, this antibacterial defense mechanism is less potent, and they therefore are more susceptible to recurrent UTIs. In terms of its diagnosis, clinically, basically the first step is to confirm the diagnosis, and we've defined it already. And then the second step is obviously to take a history, and this will include the patient's symptoms, which will include dysuria, urinary frequency, suprapubic or back pain, hematuria, but there has to be an absence of vaginal discharge or irritation. or it can actually be from self-diagnosis from patients that already know that they have a history of recurrent UTIs. You also then need to move on to the physical exam, which should include a pelvic examination. So the main reason we do a history and an exam is to basically focus on ruling out structural or functional abnormalities in the urinary tract. Post-void residuals and uroflowmetry studies can also be performed, which are basically optional for post-menopausal women. And then abnormalities in combination with other tests that are done may suggest a complicated UTI. And then in terms of lab studies, urine MCNS is the gold standard. It needs to be performed at least once whilst the patient is symptomatic. It confirms diagnosis of UTI and facilitates targeted therapy. Midstream urine bacterial count of 100,000 colony forming units is considered positive while patient is symptomatic. And you need to do a careful evaluation of the collected specimen, because there's always that risk of contamination of the specimen, which will basically lead to overtreatment or false diagnosis. Patients then need to be recultured 1 to 2 weeks post-targeted treatment to evaluate for bacterial persistence. And then further investigations that can also be done, imaging, which would include a renal ultrasound scan or a CT scan. This test is unnecessary if there's a low pretest probability that the patient actually has a complicated UTI, and we tend to overuse it even when there's no actual suspicion that the patient has any anatomical abnormality. So it's actually not routinely recommended and reserved for high clinical suspicion of urinary tract abnormality. There's also cystoscopy, and like ultrasound and CT scan is also unnecessary to perform if there's a low pretest probability that the patient has any abnormalities of the urinary tract. And then the actual indications for further investigations include prior urinary tract surgery or trauma, gross hematuria after resolution of infection, previous bladder or renal calculi, obstructive symptoms, low uroflowmetry or high post-void residuals. If a patient has urea splitting bacteria on culture, such as Proteus or Yersinia, bacterial persistence after sensitivity-based therapy, prior abdominal pelvic malignancy, diabetes, or if the patient is otherwise immunocompromised, if there's a presence of pneumaturia, fecal urea, anaerobic bacteria on history, or a history of diverticulitis. And then repeated pyelonephritis with fever, chills, vomiting, and CVA tenderness. And then an interesting part of diagnosis is what I also didn't know is that there's availability of serum biomarkers which have a potential to objectively predict recurrence in patients. The serum antibodies were actually first possible biomarkers which were found in recurrent UTI. These include IgG, IgM, and IgA levels in study patients, which were found to be significantly increased in patients with recurrent UTIs than in controls. There's also granulocyte colony stimulating factor and interleukin-5, which were also found to be significantly increased at onset in mice with recurrent cystitis. There's also macrophage colony stimulating factor, which was also found to be increased in patients who subsequently developed recurrent UTI. PSA level is also one of the biomarkers. So it's quoted that a PSA level of more than 4 at UTI onset is associated with an increased probability of developing recurrence. Low vitamin D levels were also found in premenopausal women to be associated with recurrent UTI. Other biomarkers are urinary biomarkers, which include urinary nerve growth factor, which is significantly increased in females with OAB and are considered a biomarker. There's urinary neutrophil gelatinase associated lipocalin, which is also found to be significantly decreased in young patients with first UTI recurrence. You can also get urinary interleukin-8, which also was found significantly higher in patients with bacteriuria, and it may have a predictive value in recurrent UTI in females. So as an initial step after just defining basically recurrent UTI, you need to think of preventative strategies. So this starts with basically behavioral modification and avoidance of risk factors. You then move on to non-antimicrobial measures. And then as a last measure, then you would go to antimicrobial prophylaxis. So in terms of behavioral modification and avoidance of risk factors, in terms of behavioral change specifically, many approaches have not been adequately tested to be considered as a strategy to minimize antibiotic exposure. But we do advise patients to increase their fluid intake. The target is about 2 to 3 liters per day, which has been shown to decrease incidence of cystitis by approximately 50% and decrease cystitis recurrence at 6 months. And then other measures as basically contraceptive modification. So you counsel patients who are sexually active or use spermicides about the association with recurrent UTIs. And you can then advise patients on abstinence or the use of alternative contraceptive methods, which do not include spermicides. In terms of post-coital voiding, it's not proven to reduce the risk of recurrence, but is considered a reasonable suggestion for patients and is not proven to be harmful. And then in terms of hygiene, so wiping from front to back, it's also actually been shown not to be proven to be beneficial, but it does avoid perineal contamination by fecal flora and is basically routinely recommended. And then in terms of non-antimicrobial measures, there's topical estrogen, which basically comes into play with postmenopausal females, and these can come in intravaginal estrogen installation, which can be a cream or a ring pessary, and this has been shown to significantly reduce the risk of recurrence. The effect of this is related to normalization of vaginal flora. Oral estrogen, however, has not been shown to be effective, and the side effects that have been documented include vaginal bleeding, non-physiological discharge, and local discomfort. And then we all know about this cranberry products. So lab studies have actually demonstrated inhibition of adherence of uropathogens by these cranberry products, and the mediator that is in this cranberry products is fructose. So clinical studies, however, have been suboptimal in showing efficacy in preventing the recurrence. It's not routinely suggested, but can be recommended to patients who are interested and who can also tolerate it. There's concerns with increased calorie and glucose intake, and some patients have complained about heartburn after consuming large amounts of these cranberry products. And then there's probiotics as well, but there's lack of demonstrated clinical efficacy with oral lactobacillus, but it can also be recommended in patients who are otherwise interested. There's promising results that are seen actually with vaginal capsules that contain lactobacillus crispatus, which has been shown to increase the levels of vaginal colonization, and is basically well tolerated and associated with decreased rates of recurrence. Sorry, that was meant to be to decrease the levels of vaginal colonization. And then other other non-antimicrobial measures include antiseptics, which include methenamine salts, which you can actually use in conjunction with vitamin C. These convert formaldehyde in acidified urine and have antibacterial activity. Efficacy is, however, not recommended, and routine use is not recommended, but they're generally safe and well tolerated by patients who use them. And then there's D-mannose, which is basically compounds that mimic host uroepithelial receptors for uropathogens, and competitively bind to bacteria and decrease the number of bacteria that basically attach to the mucosa. But data on this is very sparse and it's actually not convincing. And then, okay, so, and then moving on to antimicrobial prophylaxis. This is basically recommended for recurrent simple cystitis with frequent recurrences. So for example, if a patient has more than 2 recurrences within 6 months, patients who are bothered enough by symptoms to opt for antibiotics after being counseled about potential adverse events. Basically, we attempt antibiotics sparing strategies prior to antibiotic prophylaxis, but you need to ensure that you have the correct diagnosis, that you've actually done enough to prove that the patient actually has recurrent UTIs before going down this path. So it's not to be used in patients who with recurrent symptoms that are not actually related to a UTI. So if a patient comes and they say they're just feeling off, but there's actually no proven culture, then you wouldn't actually give them antibiotic prophylaxis. So you look at susceptibilities of previously isolated pathogens, which may then guide you to the decision to basically give antibiotic prophylaxis. In some patients, there's self-diagnosis and self-treatment. This has basically is practiced by patients with clearly documented recurrent infections, patients who are self-motivated and adherent to medical instructions, and have otherwise a good relationship with the healthcare professional, so that they can actually if there's any uncertainty.
Dr. Mutomba, please mute your mic, please.
Okay, so the options for antimicrobial prophylaxis include either continuous prophylaxis, and this is applied to patients who have recurrent cystitis with no temporal relation to sexual activity. The drug choice is basically you choose the specific drug according to susceptibility and patterns of prior strains. Basically, you could take into consideration if the patient has drug allergies or if they are on any other medication which would actually interact with the antimicrobial that you're going to choose. And the drugs that are often used is nitrofurantoin, Bactrim, or trimethoprim alone, beta-lactams. I put a star next to fosfomycin and fluoroquinolones because they're not routinely used, and especially with fosfomycin, there's not much data on how it's actually used or the duration and the doses for prophylaxis. So it's not actually routinely used, and fluoroquinolones come with their own complications, and they are basically used if the other drugs fail or there's the resistance to other drugs, and it's basically the only option that you have available to you. And then obviously before initiating continuous prophylaxis, you need to check your urine MCNS 1 to 2 weeks after treatment of the acute episode to rule out any high-grade bacteria. Alternatively, you can actually start the prophylaxis immediately after the treatment course of the acute episode. So there's continuous, and then you can also offer the option of postcoital prophylaxis, obviously for patients who have recurrent UTIs linked to coitus. These antibiotics are given largely in a similar fashion to continuous prophylaxis, with the difference that they are given as a single dose. So these are the antimicrobials that I've mentioned. Some of them I didn't mention before, but these are the doses that we generally use. I'll just use one example, nitrofurantoin. You can give once a day as a 50 milligram dose, or 100 milligram dose once daily. And then for postcoital prophylaxis, you would give 50 milligrams once or 100 milligrams once. And then in terms of duration of prophylaxis, so initial trial is basically for 3 months to assess for response and tolerability. If prophylaxis has been tolerated with no recurrences, the option is then there for you to continue basically with the patient and discussing with the patient if they want to continue. Obviously, the patient needs to be aware of adverse events linked to all the antimicrobials before basically proceeding after the 3 months. There's no lasting effect that has been shown after prophylaxis has been stopped, and patients need to know this. And most of these patients, even after the 3 months, will then revert back to recurrence after stopping. Drugs have been shown, these drugs for prophylaxis have been actually shown that they can be continued for up to 2 to 5 years with sustained efficacy and tolerability. Basically, it just depends on which drug you are choosing. So in terms of adverse events that are linked to these antimicrobials, there's direct toxicities, which include vaginal oral candidiasis, GI symptoms, pulmonary reactions, chronic hepatitis, neuropathy, which are linked, the last three linked to nitrofurantoin, and then development of resistance, obviously, which is basically the risk you take with any drug that any antimicrobial that you choose. And this has been documented, especially with Bactrim. There's also the risk of C. diff infection, especially with this prolonged use of these drugs. So in terms of management of the actual acute recurrent episodes, you basically manage those similar to how you would manage a simple isolated cystitis by using targeted antibiotics according to what you get from the urine cultures. But you can also, with some patients, use conservative management, like basically, for instance, encouraging increased fluid intake, which may be better for patients who are otherwise healthy with no risk factors for severe infection. And there's also other options, self-treatment, which is basically an attractive approach and has been proven to actually be effective. And then, so there are some novel preventative strategies that are under investigation. You get active prophylaxis, which has been shown to strengthen active acquired immunity against uropathogens by increasing the vaginal and urinary IgA and IgG. These come in vaccinations, which can actually be given as injection or vaginal suppository, and oral immunostimulants, which we don't have currently in our setting. So in conclusion, recurrent UTI is a common problem in urology clinics. Preventing the actual recurrence may pose to be a bigger challenge for patients and doctors, more than actually treating the actual UTI. There's evolving research that has revealed novel concepts in recurrent UTI, which include the pathogenesis, risk factors, biomarkers, and prevention of recurrent UTIs. But further studies are still needed to clarify the efficacy of our current management for these patients. Thank you.
Right, thanks so much, Dr. Siyasanga, Yekani, for your talk on the approach to recurrent UTIs we commonly see. Are there any questions for Dr. Siyasanga, Yekani?
Sam, I don't know if I can maybe ask a question if you can hear me.
Yes, we can.
Sia, so thank you for a great discussion. This is a very relevant topic. I had a few questions, and then so maybe I'll just start with one or two comments, and I've got one question. So I think that there are a lot of practices that people are trying in South Africa and the world out of desperation, because this is a patient population who suffer immensely, and we don't often win with them. So things that are maybe more supported are things like using D-mannose. So even though there isn't great literature, there was at least one RCT that was mentioned in the EUA guidelines where D-mannose was compared with nitrofurantoin, and there was, I think, equivalence in terms of effect, and that's one RCT. So the guidelines still recommend that it should only be used in clinical trial setting. But the reason I like that concept is that the concept of continued antibiotic prophylaxis is a concern in our understanding of the urinary microbiome. And there's a colleague in Pretoria who recently did a really fantastic presentation on the urinary microbiome at our South African Urogynea Association Congress. And there's a lot of people that believe that continued antibiotic prophylaxis is just going to continue to worsen the patient's overall kind of innate response and their opportunity to recover their microbiome and get out of the cycle of recurrent UTIs. And in that same setting, things that are done that we don't know much about is urethral dilatation. So that was what I wanted to ask, is whether in your reading you came upon whether there's any benefit or what most recent literature might be, and if you haven't, that's okay, related to urethral dilatation. So again, a hot topic. I think many urologists still believe that performing urethral dilatation is something to try for recurrent UTIs. So I don't know if you had any thoughts about that, Sia.
I actually haven't come across in my reading, Ali, sorry, but I know we do it in our practice. We do it in our practice, and it's one of the things that we were basically taught. It makes sense if there's it's part of a treatment of mechanical obstruction. So I can't say for sure that I've seen anything with my reading, but I know we do it in our practice, and it does provide some relief for most of the patients. And they do say they do actually volunteer the information that they actually do get relief from it. So I haven't, from my reading, come across urethral dilatation. Sorry.
Okay. So I think the most important thing for me when it comes to urethral dilatation is that the current, at least the people with more experience than me, from what I've read, the big players in urogyne or recurrent UTIs and female urology say that we should not be dilating women unless you've got a proven stricture. So it is beneficial to dilate women if you've got a urethral caliber and you calibrate them to be less than 14 French. And you're proving that you're treating an anatomical obstruction. It doesn't seem to have an indication for women that don't have proven anatomical change. It's not beneficial for physiological obstruction. It's not beneficial for Fowler syndrome, for example, but that's sphincteric. And I don't think we've got proof that it helps. So not for all women with recurrent UTIs. There was a really lovely talk, one of our speakers last year on this webinar, apologize, I don't remember her name, but a urologist from the Philippines, and she gave a nice discussion on the fact that she doesn't use urethral dilatation routinely in her patient population. Yeah. But thank you for the talk. I think it's a big topic. I think you can talk about this for ages, and there's a lot that I think we should, as urologists, try and improve in our knowledge, more studies, more knowledge, because this is badly treated worldwide, I think.
Yep.
Yeah, no, absolutely, Ellie, you're quite right. I mean, you can't just prophylactically dilate someone. You can just maybe assess that when you're doing a scope if there's an indication. but exactly like you said, there's no indication for flight dilatation. Dr. Kolu, just 30 seconds for a question. We need to close up the session.
Thank you, Sam. Very quick one. Thank you very much, yeah, for the talk. Mine is just I might have missed it, but I just want to once again point at the definition of what exactly it is a recurrent UTI. You know, when do we say this lady is having recurrent UTI? So I just want a sharpened definition of that. And the last point is that I always assumed that ultrasound examination is really should be at the very least you should do. I mean, if you're going to have diagnosed somebody with an ultrasound, I mean, with a recurrent UTI, surely at least an ultrasound must be done. And I mean, I seem to have heard her say this is necessarily not something that should be done in all of them. That's all from my side. Thanks.
Okay, so the definition is more than 2 infections in a space of 6 months, or more than 3 infections in 1 year. And then in terms of the ultrasound, I read through, I think all the 4 articles that I've put in my references said, unless there's a clinical suspicion that there is some anatomical obstruction anatomical obstruction, basically, you don't need to routinely do KUB ultrasounds for everyone with recurrent UTIs. Yeah, right, I know we tend to routinely, you know what I'm saying? I know we tend to fall for that trap. I know most of us do it because sometimes we actually we're not and there's still no clear cause of what the actual cause of the recurrent UTIs is. So we tend to fall for that basically then depend on an ultrasound to shed some light. But in all the articles I've read, it basically says you don't have to routinely do it for everyone.
Yeah, thank you so much for an interesting session this morning. Again, I just reiterate the rules of the webinar sessions or Zoom session, that people should really switch off their mics when they are logging in. This is a very important academic platform which everyone takes time to be on the platform between 7 and 8, 8:30. It really does disrupt the whole process.